welcome you to this new episode of News Desk from Intensive Care News Network, the only web channel which brings you the latest updates and stories from critical care medicine. And tonight, these are our main stories. It has been realized that acute compensated heart failure has been treated with high dose of loop diuretics for long. But notwithstanding the fact that the high dose of loop diuretics have often failed to achieve adequate decompensation. And this has been exemplified many times by the use of sequential therapies. In a recently published article in NEJM, the authors tried to evaluate the role of acetazolamide, a potent carbonic anhydrase inhibitor, in using along with the loop diuretics for the treatment of acute decompensated heart failure. Our correspondent Ankit Sharma has more reports on this.
Thank you, Dr. Anirban. As you mentioned, this original research article was published in NEJM in September, also called as ADVO trial, where the authors were testing the hypothesis whether addition of acetazolamide to high-dose loop diuretics will be able to decongest the patients of acutely decompensated heart failure. So here, it was a multi-center placebo-controlled parallel group randomized double-blinded control trial where they selected 519 patients of acute decompensated heart failure with features of congestion like pleural effusion, edema, and ascites. These patients were consecutively chosen and given a high dose of acetazolamide intravenously along with the standardized treatments of diuretics, loop diuretics. What they found was very interesting. In the study group, the amount of decongestion that was achieved in terms of what they did was an subjective scoring of ascites, pleural effusion, and pedal edema. What they found was in substantial number of patients, the rapid decongestion was achieved with use of acetazolamide. And this was the primary endpoint of the study of achieving decongestion within 3 days of the starting of therapy. And the secondary endpoint of the study was all-cause mortality at the follow-up up to 3 months. Although the two groups did not differ in their mortality, but in comparison to the previous studies, it was highly significant. Now, the foundation of this trial actually stemmed from the Class 1 recommendations of the American Heart Association guidelines for the management of acute decompensated heart failure, where they suggest that achievement of rapid decongestion favors the outcome also. The mortality is lesser in the group where the rapid achievement is done. And given the poor results from the DOSE trial and the ADHERE trial on this aspect, which suggested that only 15 to 20% of the patients were able to achieve this decongestion, so this trial holds a lot of meaning. So the study of this, the results of this trial are encouraging for the use of acetazolamide, in spite of the fact that metabolic acidosis, hypokalemia can occur with use of acetazolamide, but rapid decongestion, if it needs to be done along with loop diuretics, this can be a very useful addition. So this is all from my side.
Ankit, the important question that arises in this context is that the authors have used the primary endpoint as the features of decongestion. Now, do you think that this is too much a subjective feature in which there can be a lot of variations and there will be the tendency and the propensity to use this drug will vary from place to place and time to time?
Absolutely, you are absolutely right. And this aspect has been discussed in the discussion part also. Like a score of 0 to 10 was used when they were assessing the amount of decongestion achieved in terms of ascites or pleural effusion or pedal edema. So this point has been taken into account in the discussion as a limitation of the study. And I think the future studies and future suggestions would be to use more objective parameters to assess the decongestion achieved. This aspect has been given due weightage.
The second question that also may arise in this study, Ankit, is that the authors have excluded all the patients with less than 90 millimeter of mercury systolic from the study.
Yes,
now, there is a large chunk of patient population who might have other features of acute a decompensated heart failure may get missed from this study just because of this exclusion criteria.
No, I have actually wanted to evaluate this point was very clearly evident in the study, but I believe that authors excluded this subset of patients purely because of the reason that hypotension itself contraindicates the use of double diuretics. So that might be the reason for exclusion, because any case, if the blood pressure is low, one would not use a double diuretic regime. So I think they were justified in doing that because the primary endpoint was only to see whether those subset of patients can decongest rapidly, that is their given time was 3 days, or not with the use of acetazolamide. So that point is quite
Yeah. Thank you, Ankit, for your very
Thank you.
interesting informations on the study.
Thank you so much.
Moving on to the next news. It is always seen that delayed weaning carries a lot of adverse consequences so far as the outcome after mechanical ventilation is concerned. And a lot of patients who are on prolonged mechanical ventilation finally culminate into critical illness polyneuropathy and critical illness myopathy, both of which ultimately lead to an increase in the mortality, morbidity, ICU stay, etc. Now, measurement of the diaphragmatic thickness can be an important alternative to the observation of atrophy of the diaphragmatic muscle fibers. While the one is an entirely invasive procedure, the other entails other problems. In a recently published article, both the advantages and the disadvantages of an ultrasound-guided measurement of diaphragmatic thickness came into light as against diaphragmatic atrophy. To hear more about the study, we have our correspondent Poonam Rai from Bangalore.
Thank you, sir. Like sir mentioned, we are discussing a recent study which is investigating ventilator-associated diaphragmatic dysfunction by correlating ultrasound-guided diaphragm expiratory thickness to histological diaphragm atrophy, which was obtained by biopsy. This study was conducted in Spain, where organ donation is an opt-out option. Why opt-out option isn't a good option in this study is something we shall speak about a little later. This study was conducted in a university hospital ICU over a period of 3 years. There were 35 organ donors and 5 patients in the control group. The organ donor group were all critically ill patients who either had circulatory death or brain death, whereas the control group had patients who underwent elective thoracic surgery for localized lung nodules. The aim of the study was to assess the ability of diaphragm expiratory thickness measured by ultrasound to evaluate diaphragm fiber size and atrophy in ventilated patients. It also analyzed the impact of mechanical ventilator on diaphragm cross-sectional area and expiratory thickness. Is this study relevant to us in clinical practice? Very less likely. In this research, the controls are less than the cases, which is the reverse of what generally happens for a rarely conducted study like this. So this doesn't actually improve the quality of the study. Controls are less in the study as organ donation in Spain is an opt-out option, unlike our country. So invariably, everyone is an organ donor unless they choose to not. Now, coming to the study in particular, the donors are likely cancer patients and do not represent our ICU population, who are more likely to be septic or having other comorbidities. There are a lot of confounders like age, as generally we would have younger donors, but in this study, the mean age was 69. Old donors or likely cancer patients do not represent most of our ICU patients. Such patients might have other factors contributing to their loss of muscle strength. They have essentially tried to prove the histology suggestive of atrophy and compare it with 2 different diaphragmatic ultrasound measurements in this study. 100% patients had atrophy on histology, but only 75% had it on ultrasound guidance measurement. The donor and the control group were 2 different kinds of people with significant differences in the 2 groups. Half of the patient had sepsis in the donor group, which could either cause an increase or decrease in the diaphragmatic thickness. Ultrasound only proves that there is a muscle loss, but does the atrophy correlate with functional loss? This paper doesn't prove that ultrasound can be used at this point of time for any meaningful functional assessment in critically ill patients. This paper has failed to prove the ultrasound can be used as a surrogate to assess clinically relevant diaphragmatic weakness and relevance to weaning. The sensitivity and negative predictive value is extremely low in this study. I would have rather wanted to see if the atrophy is meaningful and it can be used in the setting of difficult weaning. Ideally, if it's up to me, I would have probably used the study in live ICU patients where we use ENMG, ultrasound guided thickness and movement, ventilator parameters, volume or pressure related indices, serially monitored repeatedly over days with biopsies at intervals to see if the loss correlated with functional loss. We could then use ultrasound to assess its efficacy in diagnosing ventilator-associated diaphragmatic dysfunction and its implications on weaning.
Going on to our next news item. It is known that in septic shock, the first hour and third hour bundle plays an important role in reducing the mortality. But a recently published study in the critical care medicine has gone one step further. It has identified a pre-hospital bundle consisting of antibiotic administration and hemodynamic optimization by at least 10 ml per kg per hour of fluid decreases the mortality in septic shock by almost twofold. Our correspondent, Dr. Mrityunjay Kumar, brings more update on this study.
So this study was conducted in a retrospective observational way in the French ICU, French mobile ICU's data. And what they did was they tried to find an association between the intervention that they did. Intervention which was done was one particular group, like they just observed which all patients received pre-hospital antibiotic therapy and fluid resuscitation with at least 10 ml per kg per hour before coming to the hospital. So that was the pre-hospital bundle that was composed of antibiotic therapy and fluid optimization with 10 ml per kg per hour of the fluid. And they found that they collected data from May 2016 to May 2021, and it was like enrolled some 529 patients, out of which 354 fulfilled the criteria, and only 20% of patients received both pre-hospital antibiotic therapy and fluid optimization in first hour bundle. And they found that in those population, there was significant reduction in 30-day mortality and 90 days mortality. Actually, the relative risk, the risk reduction was 0.56. And adjusted RR was 0.52. So it was almost brought to the half. The 30-day mortality came down to the half. And what they found was the other limb, the significant, there was 33% of population died on 30 days period. So that was the observation that they did, sir.
Mrityunjay, in the context of this study, the important question that arises here is that a lot of actions in the implementation of pre-hospital bundle is based on speculation. Now, do you think, is it correct,
yes, sir,
or is it ethical to use antibiotics based on such speculative findings?
Sir, all of us are aware that sepsis and septic shock patients are the sickest group of patients that come to any hospital. And so what if we don't give treatment as per the surviving sepsis guideline which came recently, that also suggests that in 1 hour bundle, if we give proper treatment after the early recognition of the condition, so that can affect the decrease the mortality to the significant level. So if you look at that way, that if that perspective, I think giving antibiotics is justified within 1 hour bundle, provided there is evidence of sepsis and septic shock that you detect in a patient.
Okay, I get your point, Mrityunjay. The second question is that they implement it through a mobile ICU. Now, how well equipped should such a mobile ICU be in order to perfectly implement such a pre-hospital bundle? involving such rapid action of fluid optimization and antibiotic administration?
Yes, sir. So this mobile ICU has to be equipped first. The manpower, I'm going to talk about the manpower. The manpower should have, of course, it is a mobile ICU, so we should have a driver. We should have a physician who is trained to deal with such conditions and have a proper knowledge of the conditions and how to do it in that golden hour period. And then the staff, nurses and support staff should be there. Along with that, we should have monitors to find out whether the patient is and clinical precision to detect such condition at the earliest, and that should be followed by the various drugs to give the organ support to the patient in the immediate period, and that will include again antibiotic therapy and fluid resuscitation that should be given, and noradrenaline, which is the first vasopressor to be inotrope to be given in such patient. So that can be given for the periphery for a brief period of time. So all these things should be part of the mobile ICU, which is planned to deal with such patients in the golden hour periods.
Probably we need to plan it out much in advance, or
Yes,
good
sir.
mobile ICU before implementing. Thank you, Mrityunjay, for this very interesting update.
Thank you, sir. Thank you.
Going on to our next news item. The use of antibiotics in acute pancreatitis has always been criticized for reasons more than one. And despite this fact, the composite nature of the illness, fueled by illusionary practice, often compels the physician to use antibiotics. In a recently published study, the procalcitonin guided antibiotic use has been discussed as a means of cutting down the antibiotic usage in acute pancreatitis. Our correspondent, Dr. Priyanka Harisinghani, has more.
So this was a very interesting study published in a UK. It was performed in UK Manchester Hospital. It was also known as PROCAP trial. It was based on the hypothesis by the authors that differentiating inflammation, systemic inflammatory response syndrome from severe bacterial infection in patients with acute pancreatitis is extremely important in guiding the course of treatment of the patients. And so on the basis of this, the authors aim to distinguish bacterial infection from inflammatory response syndrome by using procalcitonin based algorithm to differentiate the two. So in this study, eligible participants who were aged more than or equal to 18 years were recruited to participate in the study in 1:1 basis in the procalcitonin group and the usual care group. So in the procalcitonin group, all the patients were given antibiotic treatment as per the protocol based on procalcitonin. That is, if the serum procalcitonin level was less than 1, then the antibiotic was discontinued, and if serum procalcitonin levels are more than 1, then antibiotics were initiated and continued. So procalcitonin was repeated at 0 for 7 days and weekly thereafter, and then antibiotic therapy was guided according to the procalcitonin levels. In the usual care group, procalcitonin was measured only initially on admission and was not followed thereafter. The primary outcome was use of antibiotics during the index admission to hospital, and the findings of the study were that 260 patients out of the 260 patients who were recruited to participate, 132 were in the procalcitonin care group and 128 were in the usual care group. So 45% of the patients documented antibiotic usage in the procalcitonin group, which was significantly lower as compared to the 63% of the patients requiring antibiotic therapy in the usual care group. So in the end, the authors concluded that the use of serum procalcitonin in patients with acute pancreatitis will be extremely helpful in differentiating systemic inflammatory response syndrome from bacterial infection, and hence it would aim in better antibiotic stewardship and would reduce the harmful effects of the antibiotics and reduce antibiotic resistance.
Priyanka, from this study, what seems to be the major limitations that either the authors have discussed or which becomes apparent while going through the methodology and the results?
Actually, in this study, the authors have included patients of acute pancreatitis, both from direct admission and from the referral from the tertiary care hospital. And also there is a lot of global variation of the etiology of acute pancreatitis amongst various geographical regions. So they should have included maybe, this was just a single center trial. So they should be including several trials from, the study should be conducted in several centers across the world to make it more generalizable. Then only the findings will be generalizable to the.
The other thing that comes to notice, Priyanka, is that in this study group, only 14% of patients had prior diagnosis of acute pancreatitis. Why is this percentage so low?
It is in collaboration with the previous studies that for these acute pancreatitis patients are requiring admission to the ICU, 14% is in collaboration with previous two studies performed in the same geographical region. Maybe it is the geographical region UK. The study was in UK, London. So maybe it is because of that, but it's not significant, as in it was similar in both the groups. So it won't be a source of bias to us.
Thank you, Priyanka, for this very interesting update on the subject.
Welcome, sir.
Friends, this is all we have for tonight. Keep watching us at www.icnn.co.in for all interesting items of critical care medicine on every second and fourth Fridays, and our usual talk show, Talking Straight, on first, third, and fifth Fridays. So till we meet again, from all of us in this news desk of ICNN, Shabar Khayat, Shubharatri, good night.